Good day, my dear postgraduate students. We shall be continuing with the gross pathology of the large intestine. In this session, we shall be seeing the neoplastic lesions of the large intestine. Game, I hope you people would have found the expansion. It is gross and microscopy explained. We are towards the end of the previous class dealt with the ulcerative lesions and the polyps. In the ulcers, we had seen the Crohn's disease, wherein there is a thickening of the wall and then there is a narrowing of the lumen, producing what is called as a lead pipe or a hose pipe-like rigidity, creeping fat, etc. The ulcerative colitis, on the contrary, is limited to the colon with the terminal ileum involvement in some cases, which is called as backwash ileitis. Otherwise, it is a continuous lesion. What we are seeing on the screen is a thinning of the wall. There is no thickening as such, but still there are multiple polyp-like structures which are actually pseudopolyps. Pseudopolyps are not regenerating lesions, but on the contrary, they are all tags of mucosa which are there. There can be still a potency for malignancy which arises from the crypts and not from the pseudopolyps. And this is our class on the familial polyposis we had seen. I told you that there is a 100% chance of a malignancy. And which of these polyps is going to turn malignant, we do not know. As a result, the endoscopist and the surgeon will be scrupulously following it, and whichever becomes larger and develops some kind of a pleomorphic appearance will be biopsied and then sent to the pathologist. In fact, here it is the endoscopist who makes the first diagnosis and not the pathologist. Polyp, as I mentioned earlier, it is a lesion which promotes or rather projects above the surface. Here there is a polyp. This is a stem in which there can be a fibrovascular core, and this is the epithelial element which is proliferating. So this is a clear case of a pedunculated polyp. And this is a polyp over here, and it can be turned malignant. In fact, even the Ackerman says adenomatous polyp is also treated as a dysplastic polyp prone for malignancy, which has to be followed. There can be an invasion at different levels. In one, you find that there is invasion of the polyp into this. In such a case, a polypectomy will be adequate. Later on, you find that there is a marked involvement into the neck of the polyp, later on into any part of the stalk, and finally, there is an invasion beyond the stalk. This is one good method of grading which people can draw for your theory answers also, called the Haggett levels. There is another way of grading the polypoid lesion based on the invasion. It is called Kikuchi's method of grading. All are denoting the submucosal invasion. In one, I find that the inner 1/3 or the superficial part of the submucosa is involved, whereas in grade 2, the mid portion is involved, and in grade 3, there is an invasion of the outer portion of the submucosa. This is a muscular layer, we have not gone into it. So these two levels, you people, please remember. And Kikuchi, you would have heard this name elsewhere. These are all Japanese people who have resorted to a greater technology. The flexible endoscope designed by them have been able to identify the lesions much earlier. That is why early gastric carcinoma is common in Japan, but then it has got a better prognosis because of earlier diagnosis. Grossing of a polyp. In this session, I told you that I'll be dealing with the methods of grossing. Here, a polypectomy has been done. A stalk is here, and this is the lesion, a pedunculated polyp. It has been cut parallelly, and then one slice is taken along with the stalk. It is bisected, put into a capsule. It is a sessile polyp over here, which again is cut into multiple slices, and they are given the individual placement in the capsule. They should be mounted as individual sections. Greater importance is for the invasion that is to be made out. Description of a neoplasm. This, of course, you people will be doing in your grossing, and you are not totally new to this. But always think of these subheadings: the number of lesions, the dimensions, what is the external appearance, then whether there is any granularity or nodularity. These are two different terms. Nodule is generally larger. Granularity is multiple sand-like particles. It can be tuberculosis, it can be metastasis, and adhesions again can be because of inflammation or infiltration. Mesentery, what is the state of it? Whether it is thickened or the vessels are distended. Lymph nodes, we'll come to it later, of great importance. Any thrombosis of the veins and any other abnormality, such as the diverticulum, so on and so forth. So this will be important in grossing. Look at this one. Earlier I had told you something about a polyp, and in this case I am finding a lesion that is coming from beneath the mucosa. It is probably from the submucosa or even lower down, yellowish in color and more smooth outside. So it is not a cauliflower-like growth that we usually see in a malignancy. The yellowish tinge might denote that it is a carcinoid tumor. Secondly, the pseudopolyps can be because of, it is a polyp as such, but not a mucosal polyp. It can be because of a lymphoma. It can be because of a leiomyoma arising from the smooth muscle. All these should be borne in mind. And in some areas of the GAT, we can get the gastrointestinal stromal tumor also. These differentials, please be fluent with. Again, the tumor, you'll have to mention the size of the tumor. What is the circumference? This is a very important term that I learned just now. Always we are concentrating on the size and then the depth of the tumor. What is mentioned, there are some people who have done very great work in the grossing of the specimens. They tend to take the circumference of the wall that is involved. Thickness, we all know the depth of penetration and the distance from the resected margin. What is the mesenteric margin? Uninvolved mucosa, fat, lymph nodes, etc. And to describe all this, they mark the different regions by different colors of ink. Mesentery, for example, is black. Serosa can be blue. Others may be with the red also, the resected margins. I would like you people to kindly go through this text on the lymphatic drainage and the nerve supply for you people to by heart and write. What I'm interested in this is, so this is a beautiful picture taken from Jemison. He is an anatomist actually. One book that I liked when I was a student. So this is the mesentery, and then the nodules here are all the lymph nodes that you people can see. And I've encircled. There is a blue region and a black region. What do they denote? They will be the superior and the inferior mesenteric group of lymph nodes. And also there is something called as the epicolic or the paracolic group of nodes, which you should have into consideration. So these are the superior nodes, inferior mesenteric nodes, and lower down that can be the paracolic group of lymph nodes. Please remember these. Again, the same picture, I would like you people to go through the lymphatic drainage, because definitely they will be asking you about the lymphatic, and this class is not about the histological or the WHO classification, it is about grossing. Normally, I believe in this. A question should not be a display of one's pomp, but instead it is to be to derive and judge the student's knowledge. What are the differences between these two? This, let us assume that this is going to be the right side and this is the left side. A classical question that has been asked from our undergraduate day onwards. So what are all the differences that we people can think of. So we all have the ability, but it is the difference of how we use it. And apart from that, you will have to look for the lesions. For example, there is an ulcer over here, and then there is an attachment. What are all the things that we'll have to look for in the mucosal and the external surfaces? That will be whether there are any scars, perforations, loss of rugosity, thinning of the wall, thickening of the wall, adhesions, granularity, lymph nodes, engorged vessels. And going back to the earlier slide, the right side, it is supposed to be more capacious and it will be a ulceroproliferative or a proliferative lesion. I told you that the differential diagnosis can be hyperplastic tuberculosis. On the left side, whereas it is more constrictive, as a result of which the patient will be developing symptoms of constipation, and then the diagnosis will be much earlier. Therefore, the left side is supposed to be a better prognosis. But that is all old story. Kindly go to my detailed class on the serrated lesions of the intestine. That is an essay question for you people, taken from recent advances. I would like you people to go through it. I spent a lot of time and effort on it. The method of classification, of course, the Duke staging. There can be varying methods of staging, or year after year there can be some improvement on it. But this is the Duke's classification. So this is the mucosa over here, and this is the serosa with the blood vessels. The tumor is going deeper down. I would like you to kindly go through this and memorize it. And the measurement, as I told you, it is generally the length and the breadth that we count, but also the circumference we should be taking into account. And look at this. Though it is large, ulceroproliferative, and capacious, you find that it will not be causing an obstruction because the cecum itself is quite large. This appears to be a very simple diagram of paramount importance. Even as I was preparing for these classes, I happened to see a couple of YouTubes where they have splendidly displayed the skill of doing a grossing. I would advise you people to kindly go to them if time permits. Here, we should have a very clear concept. One common question that they will be asking is, where do you give the bits from? And secondly, when we are doing the grossing also, we are extremely responsible. So let us assume that it is a total colectomy specimen along with a bit of a sigmoid colon, sparing maybe the terminal end. Look what all they have done. Wherever they have given the bits, it is in a longitudinal manner. So it is parallel to the long axis of the bowel, wherever it is. That is the dictum. Secondly, they have taken from the resected margin. It can be either an annular, a downward shape, or a circumferential one. But it can also be longitudinal. This is also possible. This is actually more important when the tumor is towards the end. Either of these should be there, but we should be careful to mark the end that is towards the resected margin and another end that is more proximal. So this will be important. Similarly, here you find that there is a circumferential bit that has been given. Lymph nodes, wherever possible. The number of lymph nodes, they say it should be anywhere between 10 to 12, not less. If a student has given only 2 or 3, it is the responsibility of the senior faculty to go back to the specimen. Again, all these are important. Any of the margin, appendix we had already mentioned, ileal margin, bits along the long axis, any representative sections, area of thinning, area of perforation, area of thickening, area of congestion, it has to be sampled. Polyps, obviously when there is a malignancy, the polyp adjoining will have to be sampled also. Fissures, rectum, lymph nodes as I had mentioned, and the mesentery. Mesentery also look for thickened vessels. And this is one. You find that if this is going to be a tumor, again, longitudinal bits are taken. The logic is very simple. We say that there is a mucosa, submucosa, inner circular, outer longitudinal muscle. If I am going to give a bit in this direction, it will be changing the histology. It will become inner circular or inner longitudinal and then outer circular. In order to avoid that and to maintain the histology, it has to be this. Dictums are dictums, do not change. And according to the state of infiltration, you find that all the layers should be representative. If it is going to be extremely huge, then there is some amount of justification in bisecting it. Even otherwise, I would prefer a bisection like this rather than part of the layers coming in one slide and another part another. So this is the way you people will have to do the grossing. Beautifully, it is a line diagram in case you are getting something. Nowadays, they are asking wonderful questions, mostly applied pathology. I would like you people to kindly have some line diagrams like this, which will make you score above the others. So, yet another schematic picture. This is what drawing. You find it has to be perpendicular or parallel to the long axis and perpendicular to the edge. And these can be the bits from the resected margin. So this is an obvious lesion. You will have to look for anything elsewhere also. And when I cut it and give the bit, it is going to be this kind of one. It is not possible for me to include everything in one slide. Therefore, it can be bisected. Always have part of the specimen preserved with the original specimen so that you can always reconstruct and look back after you people see the slide. This is called post-biopsy wisdom. Lymph nodes. Minimum at least, here it says 14. Some books give it as 10 to 12. Do not be happy with 1 or 2 nodes. Look at this. There is a circumferential bit being given. Again, they are giving repeated bits and they are able to identify at least a couple of nodes over here, which the junior PG can miss. So we have to be very meticulous. They have done some amount of inking also over here so that we do not miss it when a section is being taken. Anorectum is another region, and there is something called as TEM, transanal endoscopic microsurgery. Nowadays, laparoscopy, microsurgery, these are all the things. But then whenever we do something, we should see that it is representative and the details are very clear. How far is it from the resected margin, and whether it is radial, and whether it is a transmural penetration that is over there. And there is a other margin also that has to be taken into consideration. And these are all the types of surgeries. It can be an open surgery, or it can be an endoscopic surgery, or it can be a radical or a laparoscopic surgery. These types of surgeries you people should be having in mind. And to summarize, these are all the things that we people have seen in both the classes. What are all the normal anatomical formats, the diverticular, etc., differential diagnosis for ulcers, differential diagnosis for polyps, differences between ulcerative colitis and Crohn's disease. My dear students, for heaven's sake, do not segregate theory from practicals, gross from autopsy. All are interlinked, and the questions also will be such that. So whenever you answer in such a way, you will be able to score marks. WHO classification will go hand in hand. Supposing you are answering excellently well in your grossing, they will obviously ask you the histological thing. They can take you up to a molecular level, which we may not answer. The normal dictum is take the student to a level where he or she is not able to answer. That is the cutoff mark or point for that particular student. Then otherwise they will not be able to gauge you. So the lymphatics, what are all the megacolons? These things we have not touched upon, hemorrhoids and prolapse. You people are all doing the grossing. All of you are doing an excellent work. Only thing we are not methodical, we panic. And I would advise you people to kindly read my classes, open your book. It can be either Ackerman or Robbins, and keep reading it. These are some wonderful references that are over here. And the classical book that is there, Shamim Sharif, also you people can have along with you people. And Autosapphire is another autopsy book that I always used to recommend. It will be giving you the various differential diagnoses and the conventional questions which we students are not familiar with now. Anyway, it is my duty to take something to you people so that you benefit from it. These are all the wonderful review articles. There will be back references. Kindly go to them and improve your knowledge, performance, marks, and career. We will meet again.